So we'll wait a couple more minutes to see everybody joining. So we're gonna have three cases today, which are good and interesting cases, and we're gonna have one presenter of one of the cases, and the other cases will be presented by us. So I think it's 3 o'clock, so we can start. Imad, if you can give now chance for Farouk to start with the first case.
Hi everyone, my name is Farouk. I'll be presenting a case today. I'm one of the complex spine guys in Belfast. Am I supposed to share the presentation
Yes.
from my side?
Yes, you're supposed to do that.
All right, just give me 1 minute. Let me do that. Okay, share. Photos, iCloud screen. Okay, broadcast. All right. Here we go. Okay. Now I will go back to my screen. Okay, there. Okay. Can you guys see the presentation?
Yes, we can see it, Farouk.
Yeah. All right, brilliant. I'm sorry my picture went tilted. I couldn't do anything about that. Okay. So we've got a very interesting case, to be honest. So this 30-year-old gentleman, self-catheterizing since the age of 15, presented with 6 months history of left-sided intermittent leg weakness, worse with exercise, progressing to the left leg weakness in the last few weeks. Oops, sorry. And on examination, left lower limb power was 4 out of 5. There was hyperreflexia and clonus. Romberg's was positive. Patient has been self-catheterizing for the past 15 years, which is unchanged. Rest of the examinations were normal. There were no signs on his back as well. No tuft of hair, no nothing. No. This is the pre-operative imaging. So let me zoom it a little bit. Okay, so basically what we can see is a very nice whole spine T2 and T1 there. And let me scroll it up a bit. So striking things in there. There is low-lying conus. There is tethering of the cord. There is some edema in the cord, lower cord. And there is vascular signal dorsally in the cord going from the lumbosacral region almost up to the upper thoracic lower cervical region. Okay, and there is a lipoma as well. Let me just focus on that. So here we got a spinal lipoma there, which this is a little bit interesting because by Pang's classification, it would be a chaotic one. By the Neurosurgery classification, it would be a type 2 actually. There is the conus is not very well formed completely, and it comes down, and there is dural defect, there is facial defect, there is neural elements going into the cutaneous tissue. So that is that. And then let me zoom back a bit. So multiple things going on here. Yeah. Just to name a few: tethered cord, low-lying conus, type 2 Morodo spinal lipoma, and vascular markings in the dorsal of the spine going from the caudal right up to the cranial half. And so we got a DSA done for the patient. I don't have the original DSA done, but this is the DSA and the day of treatment. And they found a spinal dural AV fistula arising from the median sacral artery, and they embolized it. We have a very good set of interventional radiologists. They saved us from the trouble, and they embolized this one. And this is the post-operative imaging. As you can see on the myelogram, the fistula is taken care of. You can see on the MRI, there are no vascular markings left. Okay, the edema is this is right immediate post-op, but the edema is already slightly bit less. Okay, so got a couple of questions for the board. Number one, what surgical approach would you have adopted if interventional radiologist had failed? That is the main question, to be honest. Number two, is there any merit of untethering the cord given that there is 15 years of history of self-catheterization? I think we know the answer to that. And number three, when would you consider operating on the spinal cord lipoma? Thank you very much, guys. That's me for the case.
Farouk, was the patient seen post-operatively?
Oh yes, sorry, there is more. And post-operatively, sorry. So post-operatively, actually, post-operative day number one, the guy started walking. We actually discharged him. We just kept him just to keep an eye on him for a day or two, and he walked home. Post-operative, he was fine. He had no problems. I mean, he still self-catheterizes that he's been doing for past 15 years. Okay, but nothing else changed.
Yes.
He's back to his baseline.
Okay. So yeah, that's indeed interesting case, and it's something that is not very that's not very often, at least in my practice. I don't know what is your practice, Said? Do you want to comment on that?
Yes, I have comment. Actually, this case has three problems. Problem was one is spinal AVM. Problem two is tether cord, and problem three is spinal lipoma. Actually, as the case has urinary problem for at least for 15 years, that means the tethered cord is a chronic problem. Both tethered cord and spinal lipoma. And probably, I think the case was male, probably sexual dysfunction as well. But he didn't mention about the sexual dysfunction in this case.
No, actually, I think the patient had a baby, a newborn baby. So I think that part is working well.
No, but you said 30 years old or 30 months, 30 years old.
Yes, the patient is young. The patient is young.
Yeah, okay. Actually, I have not good memories about the spinal lipomas. In my recent years, right, our pediatric neurosurgeons also recommend no surgery for caudal type spinal lipomas. As you know, spinal lipomas can be categorized as dorsal type. These are attached to the anterior surface of the posterior dura, and transitional type and caudal type. In caudal type, actually, all the not only fatty tissues, but also all the caudal fibers are attached to the lipoma. And the dissection of these nerves is very dangerous, and probably it may cause deterioration of the symptoms. Therefore, actually, as also this is a chronic aspect of the disorder, I do not recommend surgery for spinal lipoma and tethered cord. I think spinal AVM is responsible for spinal cord problems. It was started as left monoparesis and then bilateral. I mean paraparesis. Therefore, endovascular treatment, as they did, is the most appropriate approach. If it fails, of course, we can try to do microsurgery for AVM, but I do not recommend surgery for the other problems.
Completely in agreement with you, Said. In my practice, dural spinal AVMs happens probably 4 or 5 times a year. Spinal lipomas, also not very common. I see that. In that particular case, I completely agree. This is a chronic problem. The patient is already adult, so the lipoma and the tethering is something that is that's not gonna change even if you go and remove the lipoma, even if you go and do untethering. It's unlikely that this is gonna change the symptoms. The patient, usually the tethering is a problem when the cord is elongating. This is during the growth, but in that case we don't have this anymore as the patient is way past his growth period. The AVM is the one that is causing the problems, and that has been treated with the interventional radiology, and that proved to be very effective as the patient got immediate post-operative improvement and improvement after that further. So I think that this was the necessary thing to do. With regards of at least in the department that I work, if we see patients with a dural AV fistula, we tend to act urgently, and we send the patient urgently to interventional radiology because it's a time-critical condition. And if the deterioration is progressing, then after it progressed to after certain point, even the treatment happens is there will be a lot of problems that be left behind. So that's why we send the patient as soon as possible to interventional radiology for diagnostication. And if the interventional guys are happy to treat, they treat immediately after the diagnostic procedure. If that's not possible for a variety of reasons, then the other option will be usually the same day or the day after the patient will be subjected to surgical obliteration of the fistula. So that would be my approach as well. And so that I believe that is completely in line with what would you approach the patient with. Yes, Said? You're muted, Said.
I said what I wanted to say.
Yes.
I totally agree with you.
Yes, good. So, Stacy, I don't know if you're seeing these patients in your practice.
So thankfully, this is completely out with my remit, but I do have a couple of just questions about it. So who had he seen previously? Because intermittent self-catheterization from the age of 16 is abnormal. So I assume this tethered cord was diagnosed years ago.
Yeah, so obviously there was no record of who the patient has seen before.
I assume he's seen somebody and been investigated for this previously.
Has not been investigated, no. So probably I think the patient came to see us because of worsening of his problems and mainly because of leg symptoms. So
somebody assumed it was appropriate that a 16-year-old was doing intermittent self-catheterization. So I would say that somewhere many years ago, somebody dropped the ball a bit, would be a base from my looking completely from the outside. because I say I, as a parent, would not consider it normal for my 16-year-old to have to start intermittent self-catheterizing.
Yeah.
So he probably should have been picked up earlier. That's not to say that you would have done anything differently. I'm not saying anyone would have done anything differently, but I assume he should have been worked up prior to this from the neurological point of view. And the other thing is, I assume that the gait disturbance was actually more coordination, ataxia, myelopathic type gait rather than a true weakness, because he was mobilizing at power of 4 out of 5. So he obviously could walk in and walk out in principle, but I accept he may not have been managing it given the coordination. So he had a fantastic result if he obviously went from being extremely ataxic to mobilizing presumably reasonably independently very, very quickly. So great job. He had a great result from that. But it's just a couple of comments as somebody who doesn't see these generally. As I get the occasional intradural thing sent to me, but I'm very quick to pass that on to you guys rather than managing that myself. I do all the stuff outside the dural, thank you. I prefer not being inside the dural. So I can't comment on the intradural lipomas. Outside, fine, no problem. Inside, not my field.
Another question is, even if that patient comes to our neurosurgical clinics at the age of 16, what would have been done, and if something would have been done at that point? Because yes, so this intermittent catheterization is something that is not great, but nothing else at that point had been problematic. And as Said mentioned, these lipomas, they're very difficult to operate. Well, they are not difficult to operate, but the results are not great. And if you try to remove the lipoma and to untether, quite often this could cause worsening of the condition and the symptoms. So probably even at that point, I'm not sure if somebody has seen the patient, but probably at that point, if the symptoms had not been very prominent, and apart from intermittent catheterization, there is nothing else, maybe even at that point had been a reasonable decision to leave the patient. And the patient has nearly normal life. Apart from intermittent catheterization, there is nothing else. That the patient has a family, the patient has a child. So this is probably as good as it can get with this patient.
So we think, just as an ignorant person who doesn't do this kind of work, so we think the fistula was obviously the cause of the recent deterioration. The tethered cord was just an incidental finding that we pick up on scans along the way, incidentally, often without symptoms. And you think the lipoma was probably the cause of the, obviously, irritating the sacral nerve roots, hence the reason for the catheterization. Is that what we're thinking in terms of, he has 3 pathologies, but they're not all, and they're all contributing to different parts of his story, but not the recent bit is the fistula, you think?
Absolutely. The fact that after the endovascular obliteration of the fistula has significant and fast improvement of patient's condition is in favor of that.
And roughly how quickly from him having his first MRI scan with you guys to him having his obliteration was that? So obviously the scan presumably ordered by you guys from an outpatient setting or an inpatient setting, whatever. Are we talking days, hours, days, weeks, months?
So usually the tendency is to operate these patients as soon as you can, but it's not the same type of urgency as with coda equina, for example. You have a few days to prepare everything and to act usually. They are developing, the condition is progressing with this, fistulas is progressing fast, but it's progressing within days and weeks and sometimes months. It's still fast, but it's not as fast as it would be progressing with coda equina or tumor compression, for example. So you have a few days, sometimes weeks to prepare things properly, but preferably days, not weeks. Okay, so I think that was the first case. So the other 2 cases, one is tumor, the other one is degenerative spine. Farouk, you want to say something?
Yeah, can I just have 1 minute just to round up this one? There were a couple of things in this case.
Okay, carry on.
So basically, the reason for him, I mean, I understand apart from the self-catheterization part, was that this patient, and we're gonna put this as a paper. This case was very unique from a couple of perspectives. Number one, this was a type 2 Moroto spinal lipoma, which are 50% of the times they will have skin stigmata. He didn't have any. That was unusual about him. And about 50 to 70% of them will have some anorectal problems, other problems. He didn't have any of those as well. So he was very well hidden, which is very surprising for these kind of high-grade lipomas. And the other thing with this one was that we were a little bit lucky. He was already on our radar with the MRI, and he called us in that he had just, he was mobilizing. When he stopped mobilizing, we got him in, and he was embolized within 4 days of being non-ambulatory. So that's the reason why we got a very quick response with him. Thank you so much. Those are all the things I want to say.
Great. Thank you so much, Farouk. Now you can unshare your screen, please.
Thank you.
And so I can maybe present the next case that was sent from the next two cases are sent from Germany. The case that I have here as second case is sent by. Let me see if I can share my screen. Okay.
Yoris Alisauskas.
Correct. Yes. So the second case is sent by Joris from University of Saarland, that is in Hamburg. It's an interesting case. It's a degenerative case. 60. So they have treated 64-year-old female from Caucasian origin, increasingly severe pain in the neck area with feeling stiffness for months, reduced mobility of the cervical spine, also hyposensitivity in left forearm, fourth and fifth finger. She has some relatively not major comorbidities. So the patient had surgery, and the treating team decided to treat the patient endoscopically with decompression of C7 and C8 nerve roots on the left side, and also thermocoagulation of the thermodenervation of the facet joints to address the neck pain. The procedure, obviously, as per what the author is reporting, the procedure worked well for the patient. Second postoperative day, the patient already has good improvement. And then further improvement is recorded 2 weeks after the procedure. This is flexion extension X-rays, where you can see that there is instability at C7T1. For some reason, we have here a CT myelogram. Probably, I assume, I don't have that information, but I assume that the patient was not possible for some reason, maybe pacemaker or something else, to have a MRI scan. Although the CT myelogram is giving us good information. And so the questions that the authors have to the board is minimally invasive versus open cervical foraminotomy, foraminotomy versus hemilaminectomy, and the role of microinstability in planning endoscopic surgery. I think here with that case, I'm looking forward to hear Said, because yes, Said has extensive endoscopic practice, and these guys operated with the endoscope they decided to do endoscopic surgery. Obviously, later on, I will hear Stacy as well. But I would like to give the word to Said. Said, please comment.
Actually, can you go to the pictures? Can
Okay.
we see the pictures?
Yes.
As you said, probably there is a pacemaker, and therefore there is no MRI.
There's no
And
MRI
in
stuff.
this case, there is hypertrophy of the left facets in C6, C7, and C7 and T1, and causing radiculopathy. This requires decompression, foraminectomy, actually. Actually, doesn't matter, microsurgery or endoscopic surgery. You can do both techniques. Endoscopically can be performed very easily. There is no big problem. You can use standard endoscopic approach or UB, unilateral biportal endoscopic approach as well. And you can decompress both nerve roots. However, if you have no experience for endoscopic surgery, you can do microsurgical as well. I think there is not big problem, because in such a case, you can do using very small incision under microscope as well. The question number 1 and the number 2 actually are the same questions. They ask about the decision making for approach. The third question is about the micro instability. Actually, in this case, there is no instability as far as I know, but it is very interesting in post-operative plain X-ray. Can you show the post-operative image, Nikolai?
Yes, this is
As you
post-operative
can,
on screen.
if you make zoom for plain X-ray, there is a little, you can see here, small instability or spondylolisthesis after surgery. There is no instability in X-ray before surgery. I checked and compared. However, what should we do if the patient has extensive neck pain? In this case, we can try to do fusion from posterior or anterior. I cannot see a promontorium here. Therefore, probably we can go. We can do anterior cervical fusion if the patient is symptomatic. If the case is not symptomatic, we can follow and check for the times. That's my opinion.
Well, that's great. Stacy, what's your take?
So I don't do cervical endoscopic surgery, so I'm not really the person to comment on that. Now, I slightly disagree with Sayed that there is a bit of spondylolisthesis on the flexion x-rays preoperatively. It's quite subtle at 7.1, and you can see it more so on the CT myelogram, actually. You can see there's a very slight spondy at 7.1 on the myelogram. I wouldn't operate on her for neck pain. It's the first thing. In my case, your indications for surgery are her radicular symptoms. Now, she has some hypoesthesia of C8 and T1 distribution. So we're talking really that 7.1 level is her problem level. I appreciate on the CT that the 6.7 foramen actually looks worse than the 7.1, but obviously we have that query over that instability level. So I would not be doing decompression alone for a start. I would be going straight in with decompression infusion, because if I think there's instability there, I am not going to decompress alone. So if I was very convinced it was just the 7.1, and that's what her symptoms are, and she wanted to sign up, she would be getting an ACDF of 7.1 to deal with the instability and the radicular symptoms of that. Having seen the 6.7, yes, you would be tempted to go in and do a 2-level ACDF just to deal, for me, to free up that foramen in case there's a bit of crossover from the pain of the 7 nerve root on that left side there. The other question, I know she had neurophysiology, which showed it wasn't coming from her previous elbow fracture on the left side, but given the fact her symptoms are very much in an ulnar nerve distribution, I would want to make sure that it wasn't actually an ulnar nerve issue that was causing the hypoesthesia to her ring and little fingers, because again, very classically, after elbow fractures, you will get an ulnar nerve hypoesthesia. So I say, I know that they did nerve conduction studies, so maybe there's something subtle, but she could just have an irritable ulnar nerve around a bony spur around the elbow. So I would have been very wary of doing anything without assuming that is all fine. But she would have been getting a 1 or 2 level ACDF in my hands. I wouldn't be doing a posterior decompression on this in a 64-year-old fit and well patient. Why would you go in the back of the neck if you don't have to? But I say I don't do endoscopic. And I say, I think if there's any doubts on stability, you should be fusing and not decompressing alone. And I think that's proved by saying that he didn't feel there was any instability before. And I had to look hard at it, because it was only when I kind of looked at the myelogram, I thought, is there a little bit of a spondy there? And obviously the fact they'd given us FlexX x-rays when they sent the case on obviously meant there was some concerns regarding stability. So looking very closely at the flexion x-ray, there does look to be a bit of a spondy there, but I think I would be going ACDF in this case from the start. My criteria would be not to be, given the marked degenerative changes elsewhere, not to go down the line of disc replacements in her, but that's a personal thing.
Thank you so much, Stacey. I also have to say I do lumbar endoscopic, but I don't do cervical endoscopic as yet. Endoscopic surgery is the ultimate minimal invasive approach that you can choose, and with minimum disturbance or no disturbance of the soft tissues and like that. Not promoting further instability. I think I also see on that myelogram a bit of a listhesis here at the lower level. So I would be also, despite even microscopic or even endoscopic foraminotomies, I'll be concerned myself that if I do further decompression, I would increase that. Although there is more and more papers which applying endoscopic surgery, they report on good results, even with cases like that. Nevertheless, my approach here would be probably 2-level ACDF. I think that's probably the easiest for me to do. There is no discs at these 2 levels, so the patient would not lose much in case we go ACDF. Also, at least in my practice and my reflex will be, if I can do something anteriorly in the cervical spine, I would go and do it anteriorly. There is a good paper from Benzel and team. They have audited multiple databases from US and compared anterior versus posterior surgery. So they came with conclusion that the anterior cervical surgery is more favorable for the patient's outcome, less hospital stay, less ICU stay, faster return to work. So I think in my hands, this will be my approach. Maybe if I had endoscopic surgery option for this cervical region, maybe I have reconsidered, but at the minute that's what I would do as well. Said, do you wanna say something else?
No, I agree totally with you. In the previous surgery, actually, I was planning the posterior approach, no fusion. But after this spondylolisthesis, of course, we need to question the situation. Therefore, if the neck pain is so much, then we need to do additional fusion, either from posterior or anterior. The problem is in C71, the disc height is not so much. probably it is the height of the level is probably 3 millimeter. Therefore, on the other hand, I'm not sure about the location of the promontorium. If it permits anterior access. If it permits, maybe we can do from anterior, but if it doesn't permit, I go from posterior.
Yeah, so C7T1 is not the easiest level to do, but on that X-ray here, it looks like that it might be accessible. But yeah, I agree with you that definitely C7T1 is not the best and the easiest level to access, especially with people which are with short neck and when you have the sternum in front of it. Yes. Okay. I think that this was a good discussion for that case. I think probably we can conclude unless you want to say something else. I don't think we have anything else from the chat as well. So I will just unshare now. Stop share. Okay, I have unshared, and I think that we can progress towards the second case. That's the last case for today. I can give you that case as well. It's the same. That is the same hospital that is.
Dr. Jason.
Yes, that's a Jason Degianis, University Hospital Saaland again. Let me see, how can I share with you? Yes, so I can share the screen again. So the third case is a tumor case. Same hospital, but different doctors. Female patient, 61 years old, neck pain for the last 6 months, radiation towards the right arm. The patient was operated by Professor Ortel and Dr. Sanger. So the patient's examination showed right-sided deltoid weakness, 4+ out of 5. Mainly pain, mainly due to the pain. The pain and reduction of the mobility of the cervical spine was significant. So the patient's BAS score is 6 to 7 out of 10. No sensory deficit. The patient had an MRI scan and revealed a tumor. We don't have information on the histology of the tumor, but to me, it looks like there is a dural tail there, so I would bet on meningioma. So we are talking about intradural extramedullary meningioma. The approach that the surgeons developed, as I can see here, is unilateral approach only, hemilaminectomy, and like that they managed to approach the tumor enough so the tumor had been excised. You can see the tumor on the right-hand side of the slide. And the questions that the patients are asking is, what are the dangers of this operation? If there is any other way to approach this pathology. Said, what do you think about that?
Actually, as you said, this case is probably a meningioma. Therefore, if it is meningioma, it's commonly adherent to the lateral or anterior aspect of the dura. A hemilaminectomy is enough for this case. You do not need to do total laminectomy. Using a unilateral approach and hemilaminectomy from the right side, you can remove the disc. For this case, of course, you need to check vertebral angiogram before surgery, if there is any feeder, first of all, and also you need to know the location of the vertebral artery. This is very important. On the other hand, intraoperative monitoring, not only intraoperative motor evoked potential and somatosensory evoked potential, but also direct stimulator may be needed. In meningioma cases, we devascularize meningioma from the dura first, and then using CUSA, we remove first of all tumor piecemeal, and then finally we remove all the tumor. Therefore, intraoperative monitoring is very important, and closure of the dura also is very important, because you can do very good surgery, but if you cannot close the dura very carefully after surgery, you may experience CSF fistula. The other problem is sometimes these cases they can be schwannoma also. In cases with schwannoma, of course, you need to see all the nerve fibers, especially in this case. Actually, in this case, you can see C3 nerve root fibers. You need to dissect before total excision. This is what I can say about this case. Spinal schwannomas actually in T2 weighted are hyper intense when compared to the spinal cord. And meningiomas actually are hypo and iso. This is very good for the differential diagnosis, but of course you need to see also dural attachment and dural tail and other things. It's very better to know the exact diagnosis before surgery. This is very important. I think this is what I wanted to say. Do you have any other question?
I think that would be my approach as well, Said. As you mentioned, for me also will be very important to see where is the vertebral artery. I had in past approaching a tumor that was underdiagnosed in that term, and there was a tumor that was adjacent to vertebral artery, and there was a pseudoaneurysm that was underappreciated of the vertebral artery. And when I removed the tumor, I had a vertebral artery bleed, and that is not the best feeling and not the best experience that you have. It's a pretty dramatic situation. I had probably about 1.5 liters for minutes before I managed to stop the bleed. Luckily, I managed to stop it successfully, and the patient had no consequences. But these experiences are shaking you, and you remember them for life. So better to avoid them if you can, and the best way to avoid them is to do a proper imaging and information to know enough information before you proceed with the surgery. In my hands also, hemilaminectomy will be the approach that I will be using, and as you said, internal debulking in the beginning, and then dissecting the tumor from the neurostructures, and then delivering the tumor out. Why would I choose hemilaminectomy whenever I can, especially in that area? C2-3, as we know, is a major fulcrum point, and there is a lot of muscles which are attaching at that point. So if you detach the muscles at C2-3, you're risking postoperative kyphotic deformity, which if you can avoid would be good. Otherwise, later on you may face the need to do fusion surgery on that patient, and obviously that's not desirable outcome. Yeah, it looks like meningioma, but you're right. Theoretically, that could be also a schwannoma, and it's so you need to know in advance what to do, and you need to see the fibers. Yeah, that's from me. I think Said's comment was more or less similar to what my approach would be. I don't know, Stacy, do you treat this in your practice?
So I don't treat meningiomas, obviously intradural work again. Schwannomas occasionally I will treat, and it certainly looks like from the clinical photograph they gave us that they took it out as one piece. So, and from what Said was saying about the intensity on the signals, you do wonder if this was actually a schwannoma when you look at the clinical photograph now, because they did seem to take it out as one large piece. But just sort of adopting basic tumor principles here, I agree. A hemilaminectomy should be able to get at it. It looks quite well demarcated from that point of view. Obviously, you want to make sure you're fully investigated so you know what you're dealing with. We don't like any surprises. One of the questions in the chat here is just asking how you guys would actually approach the tumor located anterior to the cord, rather than being as it currently is on the right side. So if it was much more an anterior-based tumor, would you be going in through, say, a C3 corpectomy to get at this, to give you access to the front of the cord, or would you be doing this from the back?
Said, you wanted to say something?
Actually, in one case in the past, probably 10 years ago, I removed a spinal meningioma from anterior using corpectomy. It was very difficult surgery because you can dissection is very difficult. Actually, for this case, not for this case, I have some cases with dumbbell tumor. Then in dumbbell cases, you can go from anterolateral, not from the corpectomy, using anterolateral approach, especially in spinal schwannoma or neurofibroma, the foramina is larger. Therefore, in such cases, you can start from anterior. You can try to do everything from anterior. If it works, okay, but sometimes after, if you see in the post-operative image some remnant, then you can go for the second surgery for the posterior approach. Therefore, in cervical, I do not recommend in corpectomy for anterior. It's really very difficult for me. I just want to add another thing. In cases with spinal schwannoma and meningioma, because I have operated more than 230 spinal schwannoma and many cases of meningioma. I checked all cases, all CNS imaging. I mean, cranial MRI, thoracic MRI, lumbar and cervical in all cases. So far, I could find only additional tumor in 2 cases. Nevertheless, I do ask for cranial MRI in all cases, because sometimes, rarely, there may be another second tumor in the head, and your spinal surgery may cause CSF leakage and may cause ICP. Therefore, I recommend the use of CNS imaging in such cases.
That's the practice in our department as well.
Nikolai,
yes,
I couldn't understand.
Yeah, I say.
If you have,
yes, please, Tariq. Say, yeah, tell me.
This was what I wanted to say, and if you accept, I want to leave because as I mentioned before to you, I have to leave.
That's okay. Of course, Said, very, very much appreciated to have you today and your valuable contribution. Thank you so much.
Bye, Said.
Thank you. Bye-bye.
What I was going to say is that this will be what Said said will be the approach in our department as well. We would scan the whole neuroaxis to see for other tumors in case we believe that this is a schwannoma. So yes, so we search for that. We don't find so many, but I think in my practice I have found more than a couple of cases with tumors elsewhere in that occasion. So yeah, I think it's reasonable to do a neuroaxis MRI scan. with regards of anterior approach for that tumor, in that particular case, it will be very difficult, very, very difficult. So I would not go anterior. I haven't done anterior approach for meningiomas, even if they are located anterior to the cord. Usually they will be located anterior, but also more towards one side. And the spinal cord will be pushed towards the other side. So obviously the side that is towards you, you can easily take piece by piece with CUSA. Yeah, the anterior bit could be problematic. Usually it's possible to dissect that very, very carefully. In that particular case, I probably can go without neuromonitoring because it's more laterally located. So neuromonitoring is good to have in case you are in case you operate these things. But in some cases, in particular when the tumor is anteriorly located, then the neuromonitoring is very important for your peace of mind. So I think I have seen Ashraf Abuharp, one of my colleagues that I work in a close collaboration with, to do. He attempted to do a tumor that was at C7 anteriorly, but it was very, very difficult surgery, and it is not something that I would lightly recommend. And I really have to have no other options to go there. But usually in my hands, even if the tumor is anteriorly located, in that case probably is not going to be just hemilaminectomy, but it will be full laminectomy. I might consider if the tumor is strictly anterior, dissect from one side, then go and dissect from the other side after debulking. So probably this will be my approach.
The only other comment I would have is I would be the opposite thing. I would always have neuromonitoring if I'm doing a lot of work. Now, I'm not talking intradural. I don't do intradural work if I can avoid it. But I say I would certainly, if I was doing a lot of tumor work around the cord, I would usually have neuromonitoring there just from a peace of mind point of view. I know it doesn't change outcomes necessarily, but from a peace of mind point of view, I would usually have neuromonitoring. And the only other comment I had was the fact that they had commented that he had a power weakness, but it was all due to pain. So actually it's quite impressive that this gentleman or lady doesn't actually have any neurological compromise despite this large tumor. Because to say a 4+ out of 5 due to pain isn't a power deficit.
Yeah, well, that's correct. Despite, yeah, although we do see tumors which are big enough and the patients have minimal or no deficit. The reason is that these are very, very slowly growing tumors, and then the cord actually has time to accommodate. So we do see these cases which they come with big tumors, and you see that the cord is smashed somewhere in the corner, and the patient is still walking. The patient is controlling bowel and bladder and everything. Yeah, we do see these tumors with minimal deficit, despite the tumors are very big, because it is just slow growing pathology, and I think that's helping. But yeah, neuromonitoring is important to have, although there is if you go and read the recommendations of British Society of Neurosurgeons and also British Society of Spinal Surgeons, they will tell you that in these cases it's dealer's choice whether a neuromonitoring is used or not. I think that in my practice, especially if it's an anteriorly located tumor, I would use neuromonitoring.
Yeah, it was really more just a comment on the lack of neurology, just the fact they've commented on him having a neurological deficit when he actually doesn't have. It's more just that we have to be very aware of whenever we're documenting and recording these preoperatively, that 4+ out of 5 due to pain is not actually a motor deficit. If you go with the rating, it's not actually a deficit. If they have power of 4+ out of 5, that's irrelevant to pain.
I agree with you.
4+ out of 5 or 4 out of 5. But I say if you alleviate that pain, you need to be grading up based on that properly. Because I say the problem we have then is getting accurate pre and post-operative assessments of them. But I say, yes, we've all seen cases with large tumors or large masses or large whatever who have minimal deficits. I say it's always impressive to see, but it was really just a comment on the weakness due to pain. It's my absolute bugbear documentation wise is weakness due to pain. It's not actually a weakness then, it's pain. Treat the pain.
Well, we do see a lot of these problems with documenting and inadequate documenting, but that's another question. We will not.
It's a whole different topic.
Absolutely. Absolutely. Well, I think it was a good meeting and good cases presented, and thank you so much for participating in that. Thank you so much, Stacy, and thank you so much to all participants to be with us on Sunday. I will expect to see you in the next meetings. Have a good day, the rest of the Sunday, and see you soon again.
Take care.
Bye-bye.